I'm going to talk about the way that we start to look for the last decade at autism in a more personalized manner. In medicine, in psychiatry, in oncology, this term is already well known and well used of personalized precision medicine. Its definition is that we need to enable the risk assessment, diagnosis, prevention, and therapy specifically tailored to the unique characteristics of the individual, thus enhancing the quality of life and public health, and the same thing applies to autism. I was saying that we're starting to think in this way in the last decade, but that's everything that we think that we have some novelty in, and we found out that it was discovered before. In the book of Leon Kanner, which is now very unpolitically correct to say, it's called The History of the Care and Study of the Mentally Retarded. We don't use those terms anymore. In a chapter called The Dawn of a New Era, he describes in this book 11 cases that he saw. He says that the feeble-minded, another not politically correct term, are as heterogeneous a group of human beings as any other, deserving of the scientist's investigation and the physician's sympathy. Intellectual limitations are inextricably linked with the much-discussed question of the course of epilepsies, the symptoms and sequels of cerebral and endocrine disorder, the still puzzling riddle of heredity. So many of the things that I'm going to discuss today, he thought about them, he used different terms, but from the beginning it's describing the well-known phenotype of autism, the initial thoughts that this disorder is as similar as it's very heterogeneous. And as we know, this transition from the DSM-4 to DSM-5 kind of unified more all those different disorders that we used to call them Asperger's, PDD, NOS, CDD, etc., and eliminated all those terms, and we remained with one term unifying this disorder and called autism spectrum disorder. I would like to postulate that at least we should have added S and saying that there are several disorders that we should relate to in spite of the many similarities that we see in our patients. We do have those basic characteristics and symptoms that are described in DSM-5, which I really think it advanced our knowledge, and it's very well written. But with these unifying symptoms, we do have some differences in the development of the children with autism, in the trajectory. Of course, we know that there are gender differences. More and more papers appear in the differences in the ASD in girls and in boys. And we know that there are specific genetics and also other etiologies. As you saw, one of the inherited genes is the Fragile X syndrome, which, of course, we need to examine in each child with developmental problem, especially with autism, and we not only expect a different trajectory in those children, but also we have emerging treatments. And so there are the core characteristics and impairments that we know in ASD of the social interaction problems and restrictive and repetitive activities, but we also know very well that there are related disabilities, as even Kanner mentioned, there is epilepsy, there might be cognitive impairment, and also we know that we see frequent comorbidities psychiatric at different ages, and also some more organic comorbidities like sleep problems and gastrointestinal problems. So even by describing the general phenotype, we see many differences at different ages and in different children. If we look more developmentally and we divide ASD in the way that we usually divide the developmental axis by motor development, fine motor skills, social development, and language, in different individuals with ASD, we can see different problems. In some, they would have more fine motor planning problems, visual motor problems. In some children or adults, we see more problems in terms of language development. Of course, some would have more difficulty in terms of gestures and some less. And either very big difficulties in motor planning, or on the other hand, some motor abilities that seem very unusual, like you saw yesterday on stage for the last show. The parents that brought the teenager that was juggling here, I think you saw very well that motor planning was not one of the traits of his autism. Also, we know very well that there are sensory issues that might be very different in different children. In terms of language, some will have very good language, but on the other hand, problems with humor, with pragmatics, and other language difficulties. Of course, the theory of mind is a very common issue that we see. And in terms of motor development, we see also problems with the repetitive behavior, motor activities, and clumsiness. But when we try to take all those traits and all those disabilities that we see in different persons, we can discern that they are somewhat different by different trajectories. When we look at different syndromes determined genetically versus children with autism related to prematurity or brain damage, or some double hit, some combined etiology, then we can discern that, for example, in brain damage, there are more issues of motor problems and fine motor skills, less than social development. And on the other hand, in some of the autism-related kids, we see more problems in the social development than in the other areas. In terms of also language and fine motor planning is more prevalent in specific gene disorders. And also we have some other issues that would bring us to the thought maybe there is a combined etiology. So at least from this point of view of the initial development, we see there are significant differences in the early markers and early development of children who develop autism according to their specific etiology. We tried to think about it, actually we started to think about it during my training many years ago, but it took us a long time to publish it and to classify children. We took the American database from my training and our Israeli database, and to divide the children into what we knew then of being symptomatic, like children that we identified neurological disorder, genetic disorder, or cryptogenic, that we assumed that there might be some etiology, but we couldn't pinpoint, and we initially thought prematurity. After many papers came out linking prematurity to autism, and a group that we didn't have any evidence of a disorder, and we classified this as idiopathic. By the way, that's the way that we classify epilepsy, so that where we took those models, and we found out that when we classify those children in those groups, they are quite different in terms of diagnosis, in terms of developmental history, and in terms of comorbidity. And one of the very trivial differences was the gender distribution. In the idiopathic group, there were the distribution that we know of 5:1 males to females, and in the symptomatic group, which was related to a syndrome, it was 1:1. By the way, we took out Fragile X and Rett, which are related directly to gender. But in spite of that, we did find significant differences, and it seems that the pathway is different according to the etiology. Another paper that Professor Tuchman allowed me to show is the relationship of epilepsy to intellectual disability. We know very well that if we have combined ASD with intellectual disability, the comorbidity of epilepsy occurs at a much higher rate. If we talk about genetic etiologies and genetic variations versus environmental insults like prematurity or brain insult, I'll discuss first some of the genetic-related autism spectrum disorder, but mainly for introducing our next speakers. I'm not going to get in depth about it, but because you're going to hear about it in the next talks. But it's well known that there were reported many genes associated with ASD. Very important ones reported from the CBER Center, and the last correction of a paper of a scientist also from CBER with a large group of epidemiology researchers published with recent assumption that ASD heritability is about 80% or 83%. By my clinical feeling is that this number is higher than the real one, because we still have these etiologies related to prematurity and brain insult that are a major and significant part, but we can assume that heritability in ASD is a quite high rate, and genetics is a big issue when we're talking about etiologies. On the other hand, we have findings in about 20% of our patients, more if there are comorbidities like intellectual disabilities. The main finding, and I'm going to repeat it over again, is Fragile X. We advise, and as you heard, every mother should be tested, and if the mothers were tested 10 years ago and more, we advise to retest the child as well. And many times we also advise to test the child even if we know that the mother is not a carrier, to rule out any mistakes. Other genes were related very strongly to ASD, tuberous sclerosis genes, PTEN gene, and ADNP that Professor Gozes is going to talk about further, and a whole list that part of it you'll also hear from the CBER group, like FOXP1 and SHAX3 genes. So the talks that you're going to hear further about are from Professor Joseph Buxman about the genetic and environmental risk architecture of autism, and using rare genetics and model systems to develop novel therapies for autism by Dr. Hala Haroni-Nicholas from the CBER Center. So I'll switch over to different etiologies that I'm not sure that you're going to discuss. One of them are metabolic neurotransmitter related ASD, which is also genetically determined. But what's interesting about it is that at least in some of it, we already have a treatment. So I have to allude to it, although it's very rare. Just briefly, for the scientists that don't know much about neuroimaging, we can use under the MRI machine a technique called MR spectroscopy, which is actually at the basis of the MRI, and by it we can reveal different metabolites that we can identify, like NAH, which represents the neurons, creatine, choline, myoinositol, and also lipids. So we can sometimes in some disorders reveal lactate that shouldn't be present there. And by looking at different areas of the brain, we can see differences in metabolites and either reveal a specific disorder or see about the population of the neuron versus population of, for example, glial cells. And by this technique, we measured metabolites in 3 brain areas of children with autism and compared it to children with typical development. And we didn't find significant differences, especially on the left amygdala hippocampal area, but also in the right, which are the areas related to language, and those differences in the metabolites were significant and did not appear in typical children. Also, by this technique, one of the metabolites that you saw here is called creatine, and it's considered stable in the brain. It's produced by the liver. And since this technique emerged, scientists started to realize that there are disorders related to lack in creatine. Those type of disorders were not well known before. And now there are 3 well-described disorders. 2 of them are autosomal recessive, and one of them is X-linked of creatine deficiencies. In all those disorders, you can see a phenotype of either developmental delay, intellectual disability, or autism, and some of those disorders can be normalized by adding creatine to the diet. Unfortunately, the 3 kids that we saw in our center with this disorder have the form that the mutation doesn't respond to treatment, and their clinical presentation was very non-specific of global delay, language problems, and a bit of a small head, kind of borderline. And the 3 kids that we saw were all boys and had the X-linked form. Another big etiology or reason for autism starts to be in about 5 to 6 last years. There were 10 or more big publications linking prematurity to autism, and the increased risk seems very, very significant, with probably 8 to 10%, so a 10-fold increase in the incidence of autism in babies with a history of prematurity. We also looked at our cohort, and we found that the percentage that we see, it's about the same that was described. The incidence is higher as the week goes down, but we do have an increased incidence also, even if a child was born only 1 month prematurely. In terms of looking at the trajectories, we can see that not only in the early development, but also later on, the trajectory might differ according to either genetic etiology or environment. When each specific mutation, and you saw the movie about Fragile X with some hints about its trajectory, it's different in terms of medical problems, evolution of symptoms, and lifelong prognosis. That's why it's very important to know the specific genetic abnormality as a cause of ASD. And we also are seeing that when ASD is related to prematurity, its course is more determined by the comorbidity, whether there are significant motor issues, anxiety is very prevalent in preemies, and also it's much more responsive to interventions. And also language and cognitive development are major determinants of prognosis, much more than the level of the autism. I put here a small paper about the trajectory of psychiatric comorbidity in Fragile X, which shows that actually the comorbidities in children are more frequent than in adolescents, so there are at least a few of the comorbidities that improve over age. We also see differences in treatment responses in terms of different response by age, children versus adults, by diagnosis of specific syndrome, by gender, and by the comorbidity or the dual diagnosis. And that's a science fiction book, but it writes it very nicely. It was published more than a decade ago, it's really science fiction about a scientist with autism, but it emphasizes there that we need to precisely target intervention by the specificities of the autistic brain. We see many advances in terms of targeted pharmacotherapy. It started with research in the area of Rett syndrome and Fragile X, but since 2009 we have more than 10,000 publications, so I couldn't quote much of it, talking about specific treatments for ASD. And I want to emphasize some of the treatments that are being researched at CBER and the Tel Aviv University. The potential of IGF-1 for SHANK3 by Professor Collection, the oxytocin, that I think maybe Hannah will talk about it a bit, and the vasopressin 1A receptor by a different group, and the NAP for ALDP from the lab of Professor Ilana Gozes. And I will finish with a small study that we did in terms of treatment. We actually looked as autism as a whole, and we recruited children and adolescents with ASD for a combined donepezil and choline treatment. The donepezil is a drug that is used for Alzheimer. It enhances brain acetylcholine. It was linked to autism treatment, but not so successfully before. By adding the choline, we thought that we might increase and give more acetylcholine to the brain. The study was a randomized study of 60 patients. Half of them received the drug and half of them received the placebo, and then one arm crossover, and we did many tests, which I show only one of them, because I want to allude to the differences. We treated kids that were 5 to 16 years old, and then we looked at them after they finished the treatment, and also after 6 months washout. So 6 months they didn't take anything, and we tried to see if the effect will continue. We hoped that we will see an effect that will continue, and we indeed saw an effect in terms of language, which was actually more significant after the 6 months. And the problem that we saw was some behavior worsening that we thought that maybe it masks the long-term effect. But when we try to discern between different groups, and I will not have time to show verbal versus non-verbal kids, but only by discerning the different age groups and looking at 5 to 10 years old versus the older group, the 11 to 16 years old, we saw a much stronger effect on receptive language also when finishing the treatment, and that sustained after 6 months, which of course we're very happy about it, to see that even after the treatment the effect is sustainable, and it's reproduced very strongly in the younger group. It also exists in the older group, but it's much less significant. So I think you heard this say many times. We actually had a debate who was the first one who said it, that if you met one person with autism, you've met one person with autism. We all know that. There are similarities, but each family and each person is different. There are short features, but we need to approach after diagnosis more individually and to diagnose and treat according to the different etiologies and the different pathways. Thank you.